We're starting this deep dive with extreme focus. This is a rapid clinical review of malignant, non-pigmented skin lesions.
Basal cell, squamous cell, Merkel cell, and sebaceous carcinoma.
We've tailored this specifically for you, the surgical resident, prepping for those high-stakes board exams. We're heading the clinical and prognostic data you just have to have memorized.
That's right. We are cutting straight to the information that gets queried in Aviva. And to keep your knowledge base razor sharp, especially with journal club reviews and clinical cases, make sure you're subscribed. This is all about efficiency in your study time.
Okay, let's just appreciate the scale here first. Non-pigmented skin cancer is the single most common malignancy in the Western world, period.
It's huge.
So let's put UV radiation aside for just a moment. What are the critical non-sun-related environmental and systemic patient factors that drive these cancers?
We need to look beyond the sun exposure, you're right. First, think about ionizing radiation, which is often, aerogenic from previous treatments.
Right.
Second, and this is crucial, immunosuppression. Whether it's drug-induced or disease-related, it just hammers cell-mediated immunity and knocks down natural killer cell activity.
It fundamentally changes the body's ability to police itself.
Exactly. It changes the whole surveillance system.
And what about environmental toxins? I feel like we sometimes forget the historical links there.
Absolutely. Think historically about soot. The classic example is scrotal cancer in chimney sweeps. That's a direct link from chronic topical exposure to malignancy.
A textbook case.
And we have to include arsenic. It used to be in old medicinal preps like Fowler's solution, and it causes hyperkeratosis and eventually cancer.
That really complicates the workup. Okay, shifting to the clinic. You have to recognize premalignancy immediately. Can you just quickly list the key conditions, the precursors?
The essential five are Bowen's disease, which is basically SCC in situ,
Okay.
actinic keratosis or AKs, those rough, scaly, sun-damaged patches. Then you've got sebaceous naivety, leukoplakia, and erythroplakia.
Perfect. Now, we mentioned chronic injury earlier. What's the specific entity involving chronic wounds that residents must know, and what's its classic presentation?
We're talking about Marjolind's ulcer. This is a squamous cell carcinoma that develops in an area of chronic inflammation or a scar.
So, for example,
Classically, you see it in an old, unhealed venous ulcer, a chronic sinus tract from something like osteomyelitis, or within a long-standing, unstable burn scar.
right.
And the key thing is, you'd be surprised how often a chronic wound has just been watched for years, and this malignant change gets overlooked until it's quite advanced.
That's the chronic inflammatory link. Let's cap this section with the big genetic predispositions. Let's focus on xeroderma pigmentosum, XP. What's the mechanism?
So XP is a severe inherited failure of DNA repair. The defect is a deficiency of the enzyme thiamine dimerase.
Okay, so what does that enzyme do?
When UV light hits the skin, it creates thiamine dimers, which are basically cross-links in the DNA. This enzyme is supposed to cut them out and repair the strand. Without it, the dimers build up, leading to massive DNA defects and, well, rampant carcinogenesis.
And we should also mention albinism, right?
Of course. Albinism, the complete absence of melanin, means zero natural protection. It just confirms that Fitzpatrick skin types 1 and 2 are inherently at the highest risk.
Okay, let's zoom in on the workhorse. Basal cell carcinoma, this is segment 2, diagnosis and prognosis. Give us the core clinical overview, including those old historical names.
BCC is the most common neoplasm in Caucasians.
Yeah.
It comes from keratinocyte stem cells in the hair follicles. It's characteristically slow-growing, locally invasive, but metastasis is exceptionally rare.
And its location?
80% are on sun-exposed head, neck, and arms. So historically, it was known as cancer des cultivateurs in France,
Yeah.
or mariner's disease, a cancer of the working person out in the sun.
You mentioned the UV link. What are the key genetic pathways here, and what inherited syndrome connects directly to them?
Most cases are sporadic and driven by UV-induced mutations in genes like P53 and, critically, PTCH1.
PTCH.
Right. The PTCH1 gene normally puts the brakes on the hedgehog signaling pathway. When it's mutated, that pathway becomes constantly active, driving uncontrolled cell growth. And that molecular pathway is the direct link to Gorlin syndrome.
Okay, so since we mentioned the hedgehog pathway, that brings up Gorlin's. How do we spot the defining features in an exam scenario?
Gorlin's is an autosomal dominant condition, a germline mutation in that same PTCH gene. The clinical constellation is key.
What are we looking for?
You're looking for multiple BCCs appearing at a very early age, distinct palmar and plantar pits, and odontogenic keratocysts, cysts in the jawbone. usually the mandible.
And on imaging.
Calcification of the falx cerebri.
Yeah.
And a critical point for pediatric cases, it's associated with medulloblastoma, which should actually be the first presenting feature in a child.
Right. Switching to the microscope now. What is the single hallmark sign of BCC histology, and which three types make up the vast majority of cases?
The defining feature is sheets or nests of small, round, basophilic cells, which are distinguished by the peripheral palisading of the nuclei.
Adipalisating.
Yes, right along the margins of those cell nests.
So?
And the vast majority, about 90%, fall into three types. Nodular, which is most common, up to 75%.
Yeah.
Then superficial and infiltrative.
Prognostically, when we're looking at a report, what specific macroscopic and microscopic features classify a BCC as high risk for recurrence? This is vital for surgical planning.
You have to break down the risk profile. Macroscopically, we worry about increasing size, but most importantly, location. The central face, the mask area.
Around the eyes, nose, lips.
Exactly. Eyes, nose, lips, ears. Also, any lesion that's poorly defined clinically. Then, microscopically, the high-risk subtypes are infiltrative and morphaic.
And you always have to check for
Paraneural or paravascular involvement. And remember, any lesion that has recurred before is automatically high risk.
that sets the stage perfectly for management. Segment 3, BCC management. Let's start with standard excision. What are the standard margins for a well-defined BCC under 2 centimeters, and how much do those margins change for, say, a large or morphaic lesion?
This is a numbers game to the exam. For a simple, well-defined lesion less than 2 centimeters, a 3 millimeter peripheral margin will clear 85% of cases.
Okay.
Widen that to 4 or 5 millimeters, and you're up to 95% clearance.
What for the high-risk ones?
For the high-risk ones, large, infiltrative, morphaic, you have to be much more aggressive. You're talking about 13 to 15 millimeter margins to get over 95% clearance. And crucially, the deep margin must always go down into the subcutaneous fat.
That's a massive jump in margin, and this is where Mohs micrographic surgery becomes so important, isn't it?
It's indispensable for high-risk lesions in cosmetically sensitive areas.
So describe the fundamental principle. What makes it different?
The principle of Mohs is the intraoperative, complete assessment of the entire surgical margin, 100% of it.
Which gives you the highest cure rate while preserving tissue.
Exactly. And the steps are unique. First, you debulk the tumor. Then you excise a narrow, shallow margin, maybe 2 millimeters, around the whole defect. You mark it for orientation.
3, 6, 9, 12 o'clock.
Right, and then you squash that specimen flat.
And that flattening is the real technical genius of it, isn't it?
It is. Because squashing and rapid freezing lets the specimen be sectioned parallel to the skin surface. This means you're assessing the entire peripheral and deep margin simultaneously in one view.
So you see tumor.
You map it back to the precise location on the patient using your markings, and you only excise that positive zone further. You just repeat that until you're clear.
That's what prevents recurrence. But what happens when you get that path report back and it confirms an incompletely excised BCC?
It happens in about 4 to 7% of cases, and it's higher in surgically tight areas like the inner canthus, the alar base, the external ear.
And the decision-making depends on where the margin is positive.
It's risk stratified, yes. Recurrence is lower for a laterally incomplete margin, maybe 17%. But an incomplete deep margin carries a much higher 33% recurrence risk.
So what's the consensus on management? Do you always go back in?
Not always, but usually. For critical midfacial sites, aggressive subtypes, deep margin involvement, or if you've used a flap that could mask a recurrence, re-excision is highly recommended.
And the guidelines?
UK guidelines often push for a wide 5 to 10 millimeter re-excision, or Mohs, but you can sometimes observe a simple, laterally incomplete lesion. And don't forget, radiotherapy is also a highly effective option to prevent recurrence, especially if more surgery would cause a big functional or cosmetic problem.
Right. Before we leave BCC, we have to list the non-surgicals, the mechanisms of action. This is a key list for the exam.
Okay, we have a good spectrum. Cryotherapy works by repeated freeze-thaw cycles. It causes ischemia through vascular stasis. Photodynamic therapy, or PDT, uses a photosensitizing chemical, which is activated by light to generate reactive oxygen radicals.
And the topicals.
You've got imikimod eldara. It's an immune modifier that binds to toll-like receptor 7, boosting the local immune response and inducing apoptosis. Then 5-fluorosil, Ifutix, a thymine analog that messes with DNA synthesis.
And finally, for the really advanced cases.
For metastatic or locally advanced disease, you have to know the systemic option, vismodegib. It's a specific inhibitor of that hedgehog signaling pathway we talked about.
That's a great catalog. Okay, let's move to cutaneous squamous cell carcinoma, segment 4. What defines SCC histologically, and what makes it so much more concerning than a BCC?
Well, SCC is a malignant tumor of the keratinizing cells. Dysplastic keratinocytes breach the basement membrane and invade the dermis. Histologically, the diagnostic feature is the presence of keratin pearls.
And its clinical behavior.
What makes it more concerning is its metastatic potential. SCC is prone to significant local recurrence, up to 23%, but more importantly, to distant metastasis, something BCC almost never does.
So the risk stratification is absolutely vital. For exam purposes, how is SCC risk stratified by anatomical site for metastatic spread? Give us the percentage breakdown.
You have to know the high-risk sites. The highest risk category is around 38% metastatic spread.
And that applies to which groups?
Two groups: SCCs that arise in areas of chronic injury, old burns, radiation sites, ulcers, and SCCs in non-sun-exposed sites, like the perineum or the sole of the foot.
38%. Okay, what's next?
Next, the lip is high risk at 14%. The ear follows at 9%. Only then do you get to the low-risk category, which is other sun-exposed sites, at about 5%.
That's a crucial distinction. What about the microscopic prognostic factors? Size, depth, and grade.
The numbers really matter here. For size, tumors bigger than 2 centimeters are twice as likely to recur and 3 times as likely to metastasize.
And depth.
The cutoff is 4 millimeters. If the tumor is deeper than 4 millimeters or it extends into the subcutaneous fat, it's automatically high risk.
And grade.
Grade is based on the Broder's system. It's about differentiation. Poorly differentiated tumors, grades 3 and 4, have a much poorer prognosis. We're talking more than double the local recurrence and triple the metastatic rate compared to grades 1 and 2.
Given those factors, how does the standard management of SCC differ from BCC?
Well, while low-risk SCC margins are often 4 to 6 millimeters, if you hit any of those high-risk features, deep invasion, poor differentiation management has to become multimodal.
Meaning?
For high-risk SCC, Mohs surgery is often recommended. If you have nodal disease, a therapeutic lymphadenectomy is required. But even without nodes, if the primary has really bad features like perineural invasion, you move to an MD2 approach, often involving adjuvant radiotherapy to the primary site or the draining lymph node basin.
That really highlights the step up in aggression. Okay, final segment. The less common but highly aggressive lesions. Merkel cell carcinoma. It's rare but deadly. What's its key etiology and the required histology to make the diagnosis?
MCC is a rare, aggressive neuroendocrine carcinoma, more common in elderly Caucasians. The key etiology is the Merkel cell polyomavirus, or MCPYV. That's responsible for about 80% of cases.
And clinically?
Rapidly growing, firm, painless, purple-red nodules, often on the head or neck.
And the histology can be incredibly tricky, can't it?
It is. On light microscopy, it's easily mistaken for other small cell neoplasms. That's why immunohistochemistry is not optional, it's required.
And the stains we need to know are?
The stains that unequivocally identify Merkel cells are cytokeratin 20, which shows a classic paranuclear dot-like pattern in neurofilament protein.
The prognosis sounds grim. What's the biggest factor we as surgeons can control to influence that outcome?
The prognosis is grim. It has a higher regional metastasis rate than even melanoma. 5-year survival with distant mets is only 25%.
So what do we do?
What we control is local and regional disease management. That means aggressive, wide local excision, often 2 to 3 centimeter margins. And since 55% of patients develop regional nodes, the focus is on MDT management and often mandatory adjuvant radiotherapy to the primary site and the draining basin.
Finally, let's cover sebaceous carcinoma. Where does this aggressive tumor typically present, and what's the crucial systemic association we absolutely must check for?
Sebaceous carcinoma is rare. It typically presents as a yellow or orange nodule. The crucial point is that about 75% occur in the periocular region, the eyelid.
And the danger there is misdiagnosis.
Exactly. They often masquerade as a benign chelation or just chronic inflammation, which leads to a huge delay in diagnosis and carries a poor prognosis. And the absolute must-know systemic association is Muir-Torre syndrome. Muir-Torre is a variant of Lynch syndrome. It links sebaceous tumors with internal malignancies. If this is diagnosed, the patient must be referred immediately to a GI MDT for comprehensive screening for intra-abdominal cancer, particularly colorectal.
Okay, there was a very dense run-through.
We've just covered 4 critical malignancies. Bring it all into focus. We went from BCC, which is localized and linked to the hedgehog pathway, to SCC, which is all about metastatic risk, stratified by depth, size, and site. And finally, the highly aggressive MCC, driven by that polyomavirus, and periocular sebaceous carcinoma, which demands a workup from your tour.
A fantastic, focused analysis. To leave you with one final thought about managing recurrence. We noted that standard bread loafing of a surgical specimen might only assess 40% of the true margin, leading to sampling error. So if standard Mohs is unavailable, what crucial technical principle applicable in any OR should always guide your excision in high-risk areas to maximize margin assessment and minimize recurrence?
You need to think about the geometry of that excision and how the pathologist is going to view it. That technique can dramatically change your reported clearance rate.
Exactly. Something to mull over for your next case. If you found this focused review valuable for your Viva Prep, remember to subscribe for more deep dives, including journal club reviews and clinical case approaches critical for your success. We'll see you in the next review.